Hello and welcome to the Connecting Africa Digital Week, brought to you in association with the 20th anniversary of AfricaCom, the biggest gathering of technology and telecommunications enthusiasts on the African continent, taking place in Cape Town between the 7th and the 9th of November at the CTICC. In this Digital Week webinar, we're tracking the rise of digital health and showcasing the mHealth technologies uplifting the African healthcare ecosystem. And we're very pleased to have with us today our webinar panelist, Taryn Springhall, editor and co-founder of eHealth News, Professor Devet Swanepoel, co-founder of the Herex Group, and Dr. William Mapham, founder of Vula Mobile. Hello, everybody, and thank you so much for joining us.
Thanks, Amy. I'm Taryn from eHealth News. We're a dedicated platform for sharing news and opinion about the people, processes, and technology that are transforming healthcare in South Africa and Africa.
Hi everyone, I'm Devet Swanepoel from the Herex Group, a social impact startup geared for hearing loss and ensuring healthy hearing in underserved populations.
Hi, I'm Dr. William Mapham. I'm passionate about improving rural healthcare, and in that regard we've developed the Vula Mobile app, which connects rural health workers with specialists.
Great, so thanks very much for the opportunity. I think that everyone who's joining us today will agree that healthcare is a really important subject. And it's not just because we want to fulfill this basic human right, but I think it's because it has such an enormous impact on just about every other facet of economic and social and political transformation. I think we're grappling with nuances around African healthcare that are different to other parts of the world who are largely connected in terms of infrastructure and ICT. But I think the overall goal and the challenge for healthcare is the same as anywhere else in the world, and that is to provide access to affordable, quality healthcare for everyone. Some of the nuances I was talking about aren't isolated to Africa, but in some instances they add an additional layer of complexity that have to be addressed or navigated within the local context. And one of those in particular includes leadership and governance. I think we're starting to see stronger leadership and endorsement of eHealth by decision makers who have seen the impact that eHealth or digital health has when applied correctly. But we still have a long way to go. I hear many people say that eHealth is not a silver bullet, and it isn't. But there's still work to be done to integrate those people and the processes and the technology for the purpose of transformation. And digital health is absolutely fundamental to that, but it's not the answer in itself. We're starting to grasp that concept, but on the other hand is governance, which is also a huge issue that in some ways is holding us back. I think what we're seeing is that when there is a need, there's often a solution that can't necessarily wait for governance structures to be perfect or even formalized before rolling out. Second issue that we're grappling with is a growing burden of disease, both communicable and non-communicable. The disease burden is prioritized in the sustainable development, directed and focused a lot of the efforts by the digital and broader healthcare community to help reduce or eradicate those disease types by 2030. But we really can't get away from the fact that the reliance on an already overburdened health system is growing, and it's growing quickly. Added to that, we have a well-known shortage of healthcare workers, and it's the highest in Africa than it is anywhere else in the world. And this has also focused digital health progress and really to try and alleviate some of the enormous burden on healthcare workers that serve huge populations on a daily basis, and also then to build on their capacity to fill the gaps in access to healthcare. I'm not going to talk too much about things like connectivity. We'll touch on it later throughout the presentation, but I won't spend much more time on resources or the cost of healthcare or procurement. I think these are huge subjects that are very complex, and they really can't be unpacked in the time that we have available. But ultimately, I think it's safe to say that very few economies have cracked the code to affordable healthcare that the local service in particular can copy and paste into the African context. But in spite of the challenges that we face and the various complexities, there have been numerous strides being taken on the continent towards better healthcare and access to healthcare. I picked a few examples that illustrate some of the points that I'll talk about later in terms of Africa as a mobile continent, and then replacing paper-based systems for efficiency, and then lastly around universal health coverage too. So you'll see from the view over Africa that Nigeria, Namibia and Rwanda have taken huge strides to digitize the medicine supply chain, as well as improve the management of essential medicines and vaccines. I wanted to include this and talk about it because when you want to overhaul a system as complex as healthcare, it's sometimes difficult to know where to start. But the reality is that you really can't have healthcare without medicine. So these countries have tackled the problem of stockouts and spoiled medicines by replacing paper-based processes and systems, and then aligning and digitizing processes from numerous stakeholders to ultimately strengthen the overall supply chain. The other thing about these rollouts, the other thing that they have in common is that they're also products of public-private partnerships, and I think that's something to keep top of mind for anyone in any country when they're working on planning and executing a modern connected health service. I've also included a focus on maternal and child health in Tanzania in this example, and then later I'll touch on what's being done in South Africa. So maternal and child health is a priority as outlined by the SDGs, and mobile seems to be the most direct mechanism to reducing mortality and improving the overall health of women and children. This is largely done through things like push notification services, vaccine and appointment reminders, advice. But in this example from Tanzania, we're seeing mobile being used to register new births. That's something that still involves lots of queuing, paper-based documentation and processes, manual processes. But here, we're seeing mobile being leveraged to streamline that process. And I think that is a huge move forward in our ability to trust the digital process, because that's another thing that sometimes is a stumbling point. And then I wanted to look at the progress that we've made as a continent to deliver universal health coverage. So Kenya, as you'll see, is an interesting example because as a country, they've had a form of national hospital insurance since the 1960s. But that system has gone through numerous overhauls and iterations, particularly in the last decade. But the fact remains that they're still struggling with issues around affordability, sustainability, increasing costs, and reliance on the health service, the same issues that many other countries are facing, including Ghana, who've demonstrated that it is absolutely possible to roll out a form of national health insurance. It's just not perfect. So taking a look at South Africa in particular, I put together a mini timeline of some of the landmarks that have shaped where we are today and where we're headed. So I want to go all the way back to 1998 because in 1998 the South African government embarked on a national telemedicine project. And this was important because telemedicine had been lauded and continues to be lauded and used around the world to great success. So in this example, the decision makers organized themselves to leverage the opportunity, especially with regards to rural health. So the project spanned across 3 phases in about 5 years, but in the end it was deemed a failure nationally, apart from one site. And there are numerous contributing factors to that, but ultimately, you could bundle it up and say, well, maybe it was just too soon, and maybe that's true, but I think while it was definitely undertaken with the best intention, the one essential thing that was left out from what was considered an IT project at the time was the human element. They handed over a top-down strategy to people in management who possibly didn't have experience in using IT very well, or they didn't have buy-in, and they certainly didn't have the budget to manage it going forward. And really what it did was it caused people, decision makers, to approach telemedicine with caution for a number of years afterwards. We're still grappling with that to some extent. But I think the example itself really highlights the absolute need for strong leadership, for a thorough change management strategy and an accompanying budget for any digital health project to really cement itself and deliver value. And then a year later, in 1999, the Western Cape government embarked on a regional medicines management project that eHealth News reported on in 2014. So again, like the other countries that we talked about previously, they wanted better control of the stocks of medicines, and not just at an individual facility level, but they wanted to do that across regions so that they could properly plan and ring fence and forecast medicines to serve the public. It was an extremely ambitious task, particularly as a single province operating in isolation, but they have been successful. I think the reason that they have been successful, but it isn't completed, I think that's important to note too. The reason I've included it as a landmark is to illustrate the lifespan of innovation. I think innovation, we often believe that because it can be done quickly, it should be, but in reality it can, and it often does take a long time. So then there's a huge gap between 1999 and 2010, when the National Department of Strategic Planning placed a moratorium on the purchasing of ICT solutions for healthcare. So within that period, it doesn't mean nothing was happening. It maybe means that too many of the wrong things were happening, and hence the moratorium. It's significant because it's still in place. 7 years later, it's pending the completion of the National ICT Strategy. But it speaks to the fact that there was a time when people were buying digital systems that were unsuitable, sometimes unaffordable, and that alone was a huge learning curve for healthcare, both with regards to the fact that we need to understand our needs before we apply the solution, and then also to approach digital health with a meaningful endpoint in mind. So not just for the sake of it, but because we have real questions, real world questions that we want to answer. In 2013, the Protection of Personal Information Act was signed into law, and a year later, we made some more progress with the release of the National Health Normative Standards Framework for Interoperability of eHealth. This was probably a huge step, one of the biggest steps we've made towards placing a world-class framework in place that directly impacts how patient records and, importantly, how health information gets shared between service providers. But it also essentially influences how the entire health system will function in the long term. So the next step from there was to put in the governance in place to guide suppliers to understand how to work with each other and to apply accountability to the process. But at this stage, we're still waiting for that development. So in 2014, the National Department of Health launched Mom Connect, an mHealth solution that's aimed at maternal and child health, as we've talked about in previous examples. But the reason I bring this one up is because while there are a number of these kinds of apps around the world, Mom Connect is considered the best within a global community of mHealth workers. So it was also the first time that the National Department backed a digital health solution and endorsed it, and it was in fact a personal project of the Minister. And so they've managed to reach tens of thousands of women to share critical health information, but the real value was really in the fact that it taught project leads, who are often academics or people who don't work in the commercial space, it taught them things like how to negotiate with mobile operators, for instance. It also leveraged the participation and was founded on the participation of primary care nurses. And so there was another learning curve there that was mastered, I would say, in terms of the training and the change management and ongoing communication with those primary care nurses who are at the coalface. So it's an example of transformation, isolated and definitely behind the scenes, but it's made a difference that can be leveraged in future, and I think it's important to note. It's also worthy of mentioning that in 2016, you'll see the National Health Laboratory Services completed their migration of over 350 sites to a single IT platform. And that, as many of you in digital health will know, a single platform is a bit like the Holy Grail. And this was huge in particular because pathology, like medicines, is another cornerstone of healthcare. And so by creating a digital pathology record, we were one step closer to a cradle-to-grave health record for more than 70% of the population who use the public health service, and it was significant. And then eHealth, or digital health, was further cemented in 2015, and then in 2017 again with the release of the white paper on NHI. And specifically talks about the necessity of eHealth to realize end-to-end medicine supply chains, as we've seen, surveillance, and then, of course, to contribute to building a national information repository and data system. And this is all for the purpose of delivering universal health coverage information that can be tracked, monitored, and calculated. So those are some of the milestones that we as a country have managed to reach. And then just looking ahead at what we can expect going forward in digital health in Africa. I think it's fairly well known that Africa is a mobile continent. I've heard the quip many times that there are more mobile phones in Africa than there are toilets. And while I know it was said in jest and that's how it was intended, I think that statement alone points to an underlying problem of inequality and a lack of basic services, and healthcare being one of them. When we're looking ahead at the growth and prevalence of digital health, I think what we're going to start seeing more and more of is a refinement of the type of innovation or solution that's being offered. So currently, mHealth in particular includes everything that's made available on a mobile phone. But there are those solutions that disrupt by novelty, but they're really targeting a population who have access to healthcare or who are insured. I think that there are some remarkable mHealth apps available to consumers that allow them to take responsibility for their health, to engage and track their personal health data and often earn rewards. But these kind of solutions are very different to those that are filling the gap in failing infrastructure. I was chatting to my Uber driver a couple of weeks ago, who's originally from Zimbabwe, and telling me how airtime, essentially, for lack of a better word, was being bought and sent and used to pay for basic services, groceries, fuel, just everyday purchases. Now, this isn't happening because there's this higher need for convenience or some great marketing by a mobile network operator. It's not that. The reality is that nobody wants to use the local currency or the bond notes that are available, and there are very few other viable options available to them. But mobile money, as it were, is one of them. And I think it really illustrates my summation of digital health or eHealth in Africa, that we maybe aren't entirely ready to scale to the sexiest, sort of sleekest, novel innovation in many parts of the continent. But innovation that's born out of necessity and harnesses mobile in addition to that is something we should really take note of. So what I've put together is a bit of a checklist, I suppose, for emerging tech and for mHealth going forward. It's really based on my observation. I have to qualify that I haven't applied any science to this. It's simply what I've seen over the last couple of years. But there is this formula emerging that doesn't need to die by, and from my perspective, if you can meet these criteria, you as an mHealth solution provider are more likely to go well beyond the pilot phase. So in the simplest sort of version of the benchmarks, mHealth or eHealth solutions have to really, first and foremost, serve a real world need. Not a want or a nice to have, but an actual need, I think is absolutely key. And equal to that, you have to be able to demonstrate its impact, not just in theory and not just in an elevator pitch, but in actual measurable gains, whether you're wanting to improve efficiencies, reduce costs, better patient outcomes. You have to be able to prove that with real world and sometimes real world data. And digital health is, we don't have a mechanism that's better, more convenient, or more available really to allow us to collect and aggregate health data. So that's definitely primary component to an emerging mHealth solution. Secondly, mHealth apps to watch are often a partnership between decision makers and experts in their field. They certainly might not start out that way, but often to really scale, the next step for innovators who have demonstrated some value is to partner with decision makers, policy makers, often government, to be able to take their solution to another level and help more people. And that brings me to our next point around funding. So a couple of years ago, there was this debate around whether mHealth should be a paid service that generates income, or whether it should become a line item in an operational budget. And I don't think we've made much progress in reaching consensus from that debate, but I do know that the consumers don't want to pay for freely available information. It doesn't matter how clever your mHealth solution curates that information. mHealth or mobile users are reluctant to pay. So what we've seen is that solutions that are well funded either by global not-for-profits or by the private sector or by the government definitely have the ability to make a difference without having to make money too. And I think that's important. And then the last criteria feeds into my first point, just around filling an actual need, and that is that mHealth or eHealth solutions that are clinically relevant or clinically validated are already miles ahead of other innovators. And I know that Devet and Will on the panel will tell you more about that in more detail and how crucial it is to the digital health landscape in Africa. So that's a simplified formula. It's those 4 points. Not to say that it won't change over time. It absolutely will. But I think that it's important to note that there's absolutely room for innovation that doesn't meet that criteria. But I think the real innovation for more novel, disruptive technology will be less around the technology and the features and that sort of thing. It'll really be around the business model that they choose to deliver the solution and still make a profit. So I think that the innovation will really be focused around how to have a social impact as well as make a commercial profit. And then lastly, just to round off before I pass on to Devet, I don't know that we would be doing any of this if universal health coverage wasn't the primary driver. I think we get stuck on the politics and the debate around national health insurance, and rightly so. It's an important enough subject to be examined in grave detail. But we also have to be cognizant of the fact that it is a huge piece of work that has to be broken down into the many pieces that make up the health system. And it means change, and that's difficult in any industry, not just healthcare. And I've heard many people offer a very tidy answer to this complex problem, or summing up a discussion with, our country can't afford it. And these people are from various countries, not just South Africa. I think it's important to note that. But the observation in itself isn't the answer. It's a critical factor to how it's all pieced together and how it will function. But it isn't alone where we have to stop the conversation and say, well, we don't have the money, let's move on and not give a bunch of people access to healthcare. I think it would be really naive to view universal health coverage as some sort of utopia where there's this connected digital health service where everything works and there's enough of everything and everyone is served. I think that we would be silly to do that. But if we start to think of it as phases of continuous improvement and managed change to eventually replace a broken and an unsustainable system, I think we're probably a little bit closer. We're edging towards aligning ourselves and heading in the right direction to be able to offer the ultimate goal of affordable access to everyone. So that was it from me. Thanks very much again for the opportunity. I'll hand over to Professor Devet Swanepoel from the HearX Group.
Hi, this is Devet Swanepoel, founder of the HearX Group and also a full-time academic still at the University of Pretoria. So the HearX Group is a social impact startup that has its focus on making hearing healthcare accessible to everyone, everywhere. The company was started as a tech rollout from the University of Pretoria about 2 years ago, and has really grown from 2 full-time persons to a team of more than 20 at the moment over the last 2 years. And the company really sees itself and has positioned itself as a social impact startup to really impact hearing healthcare in underserved areas, but also it's having impact in surprising areas that we didn't foresee initially. So just to give a little bit of context, hearing loss is the area of focus for the company. Hearing loss is called the invisible epidemic. It's an epidemic because it's extremely common. The World Health Organization estimates indicate that there are 360 million people globally who have permanent disabling hearing loss. That's a prevalence of about 5.3% of the world population. If you include milder hearing losses, that figure doubles to about 10% of the world population that have a mild or greater hearing loss. So the numbers are quite staggering, and I think the important thing to note here is that the numbers are increasing because of the aging world population, and hearing loss is very closely linked to aging. as one of the leading causes of hearing loss. And at the same time, it is one of the leading burdens of disease, considering disability-adjusted life years. So it has a massive impact on individuals, but also on economies. And at the same time, it is an invisible epidemic because it's not noticed. Clinical examination can't tell you that a young child has a hearing loss. And at the same time, also from a funding perspective and maybe a global healthcare agenda, it's been largely invisible. And that's why it's been called an invisible or silent epidemic as well. And the other challenge with hearing loss is that access to hearing healthcare professionals is extremely limited. In sub-Saharan Africa, some of the recent surveys indicate that there's one hearing healthcare provider to every million and up to 6 million people in the general population. So you can imagine that just means that hearing healthcare largely for 90% of the population in sub-Saharan Africa is totally inaccessible. So the EarX group vision is really to see that healthy hearing becomes a reality for everyone, everywhere. The mission, or the way the EarX group aims to do this, is by providing affordable access to hearing health using connected solutions that anyone can use anywhere. So the company was started with the world's first mobile hearing screening solution that was clinically validated and that adheres to international standards for medical devices or audiometers to test hearing. And this was developed and validated and published in foremost peer-reviewed journals, now about 4 years ago already. So this was part of the key for the company's success, is the fact that the solutions are research-based. It was developed at the University of Pretoria, and it's validated both in the lab but also in the field. And that's really one of the strengths of the solutions within the EarX group. The first solution was called HearScreen, a very rapid screening of hearing loss for young children, but also for adults. It takes a minute to screen both ears. And importantly, the way the solution was positioned is that it's not just a device that makes point-of-care access to hearing screening more affordable and accessible, but it's also an integrated solution that links back to a cloud-based data management system from where the data can be managed, surveillance can be done, and tracking can be done. And we also offer things like geolocation-based referrals to the closest clinics or centers where there may be medical or audiological support provided. So it's not just about a point-of-care diagnostic, but it's also about building a solution that can manage patient data, track it, and do surveillance longitudinally. So since the HearScreen product, where EarX really started 4 years ago, in the research phase, the company has expanded the offerings to include diagnostic versions of this technology that can determine the degree and the configuration of the hearing loss as well. I think one of the key elements of the solution, and this is also part of the mission of the company, is that anyone should be able to operate these devices. So the way in which we've developed the applications has really been around human-centered design. We've worked closely with users on the ground, community health workers, people in the communities, to ensure that the app interfaces and the user experience is extremely simple. We've automated test sequences so that with very minimal training, a layperson can actually conduct these tests and facilitate them on young children or in adults. So that's part of the vision, is that really it should decentralize access by allowing and empowering persons at community level to operate these devices. It's also intended to be a very low-cost solution, so it runs on Android-based phones. At the same time, what's important for us is that we do very stringent quality control measures in the environments where we're doing testing. So this also helps us to ensure the validity of tests. So for example, we continually monitor the background noise in an environment with a microphone in the phone. That way we know whether the testing in that environment is actually valid. All of that information gets captured and it's uploaded in real time. If there's no connection, it will asynchronously upload at a later stage. But that way we can continually assess the quality of the test in the field. Another thing the application does is that it actually monitors the quality of the testing done by the test operator. So we've got some smart algorithms built in that present some false presentations here and there, and depending on how the test operator responds to those, we can gather a quality index on the test operators, and that can flag us a flag on the back-end system when we need to retrain or intervene in terms of the test operators. So all of those are important quality control features that help us to ensure we can provide high-quality point-of-care access to hearing assessments in communities. We've also expanded the product offering to include a fuller selection of different kinds of diagnostics. So the most recent addition to our stable of product is a smartphone otoscope that utilizes artificial intelligence to assist diagnosis of the most common ear diseases. So this is a little hardware device the size of a pen that plugs into the Android phone, and then you can put it on a specula, put it in a child's ear or an adult's ear, and get a very good view of the tympanic membrane. That's then uploaded and appended to the patient record through our mHealth Studio app and cloud-based platform. And that way we can get a remote diagnosis by a specialist, but our artificial intelligence system uses image processing techniques, and we've trained this on a large number of pre-diagnosed images so that we can diagnose acute otitis media and other common middle ear infections with an accuracy of around 80 to 86%, which at this stage is very similar to what general practitioners' accuracy is for diagnosis of ear disease. At the same time, we have positioned HearX to be a partner-centric company and solution. So we do include other point-of-care solutions inside our ecosystem so that we can do both hearing testing and vision testing, for example. One of our partners is called Peak Vision, and their application actually lives within our data management ecosystem. So you can do a hearing test and then straight after just select the vision test and then do a visual acuity screen on a young child or an elderly person, depending on the need for this. And this really leverages the technology and just increases the impact that we can have in community level by both offering a hearing and a vision testing. And we're also working with other partners to integrate more solutions within our larger product offering. So I'd like to just share a little video that just illustrates how laypersons can facilitate both the hearing and the vision testing in really underserved communities, and then that data can then be logged and on the back end, appropriate referrals made, so that ultimately we can demonstrate an impact with the interventions that proceed from these services.
Hearing loss is called a silent or invisible epidemic. It's invisible because parents oftentimes don't realize their child has a hearing problem. It's an epidemic because it's much more common than people often believe. As many as 1 in 10 children may suffer from an educationally significant hearing problem.
The need that's being filled by this particular project is the fact that many children with barriers to learning are never identified as such. So they'll be early on they'll be identified perhaps as children who don't listen, or they're obstructive in class, or they're labeled as being stupid because they're not learning, and then behavioral problems start setting in, and then they end up falling behind in school, and it's kind of this terrible cycle that sets in, all because right at the beginning a critical barrier to learning was not identified. So I think if if we identify this barrier to learning, it just opens up a completely different life trajectory for those children.
This demonstration project is a first of its kind to offer hearing healthcare services in communities in ECD facilities. The aim of this project is to scale it nationwide so that every child will have access to healthy hearing.
They've now added vision screening as well, so that it's a complete product that includes hearing and vision screening for young children from the ages of 3 to 6. And it can be administered at scale by community workers using very simple mobile device and calibrated headsets. So it's really absolutely perfect in terms of our objectives of reaching the most marginalized children.
It allows us to test children in ECD centers so that we can detect them much earlier than actual school age. And this allows us to give them interventions such as hearing aids and other audiological support to allow them to function alongside their normal hearing peers.
That's really rewarding for us as the innovation agent supporting a team like this, you know, that they're totally committed. It's really rewarding.
So the ERIS group has rolled out its solutions now to more than 25 different countries around the world, most of them in underserved or developing world contexts. Our solutions have reached more than 70,000 people around the world with either a hearing test or with some sort of form of combination of hearing and vision testing. Some of the important partners that have really helped us scale the solution has been large NGOs like RTI International, Partners in Health, and USAID. I think maybe just to highlight some of these example projects, with Partners in Health, we've rolled out in more than 17 countries where the technology is used to monitor ototoxicity for TB patients on medication. So literally these patients are having their hearing tested on a monthly or a bi-monthly basis, and the data is collected through the mobile application, uploaded to our cloud-based server, and then we're linking our data through an API with the back-end database for Partners in Health. So we've really built it to be an agile system so that we can easily interface with other health systems through the back end. We also have run a project with RTI International, who have rolled out reading programs into schools in Ethiopia. And as part of these programs, they're also including vision and hearing screening of the children. So the teachers are actually facilitating these tests in the schools. It's now been rolled out to more than 200 schools, and the teachers are doing the vision screening and the hearing screening of these children in those environments. So those are just some of the examples of where these technologies really can be utilized to increase access at an affordable price point in ways that really never was possible before. So maybe just in conclusion to say that we've really seen the benefit of leveraging mobile technologies and connectivity, the strength of solutions that are clinically validated and that have strong research behind it, peer-reviewed publications, certainly ensure that these technologies are respected and more easily taken up in healthcare systems. And it's been a great journey to see the scale up of the technologies and the uptake with partners globally around the world. Really to see the impact increase in terms of affordable access for hearing healthcare. So I'm going to leave it there and pass it on to Dr. Mapham.
Hi, I'm Dr. William Mapham from Vula Mobile. I was kind of born as a rural doctor. My family's from the Eastern Cape. And for my community service, I worked at Mudvuleni Hospital. So this is the main road to the hospital, an hour and a half round trip to fill up with petrol. So quite a deep rural area. Very junior doctors. There are only 3 of us running a 200-bed hospital serving 250,000 people. So a lot of pressure on us to deliver a good service. And it might surprise you to know that we only had 2 weeks of eye training during our medical careers, and only 2 weeks of audiology training, which is why the HearX system is so important. And essentially, if you go to the next slide, This is an example of a letter I wrote. A patient came in with a painful eye. I knew it looked serious, but I really didn't know exactly how to treat it. So I wrote the letter, and I hoped the patient could get to Mthatha, which was a 2-hour journey away. That's the quickest way you could get there. And I hoped that he got there. And that's the last I saw of him, apart from 6 years later, which I'll tell you about just now. The other problem is that the distances between referral hospitals, or basically where specialists live, and the rural hospitals, like where I was working, is often very, very large, and the transport issues are very, very difficult to overcome. And now, as a specialist myself, you can see this is me busy seeing a patient. There are 2 students who I have to teach because it's a tertiary hospital. There's another patient waiting behind me. And in the corner, you can see a landline phone. And often doctors from rural areas would phone in, but I couldn't get to the phone in time, or it would ring and ring and ring, and eventually one of us would get to it. Or they would phone and I wouldn't understand exactly what they were trying to refer because they didn't give me enough information. So the referral system was very difficult to manage. So to solve that problem, we created the Vula app, literally made by healthcare workers for healthcare workers, very much a bottom-up approach as opposed to the top-down approach, which Taryn talked about earlier. And essentially what it does is it links the primary healthcare workers directly with specialists. And one of the bonuses of being an app is that the communication is asynchronous. So the rural doctor can send the information in his or her own time, and the specialist can respond between patients and is not interrupted all the time by phone calls. Vula started with ophthalmology, or just purely with patients with eye conditions, but it's since grown to 14 specialties. And it's growing quite rapidly now, with the number of patients being seen in every quarter escalating. 2 of the most recent specialties we've added are pediatrics and obstetrics and gynecology, and those are part of the national strategic plan for healthcare, one of the 2 national priorities. We also have ENT, which could complement the HEARX system, as well as cardiology, orthopedics, dermatology, burns, and a range of others. Yeah, it's just a quick list of some of the departments using Vula today. So there's quite a range of different units in different provinces, and it's essentially spreading by word of mouth. We've never really had a marketing budget. It goes where people want to use it. It's designed so that it requires no training at all. If you think about it, no one trained you to use Facebook or Google, and we followed the same design principles in that regard. It's a very simple app. Essentially, the primary healthcare worker logs in and they can fill in a patient form. You can see it's a very simple form, and we like to say that if it takes more than 2 minutes to fill it in, then we need to redesign the form. If you think about it, in such a busy rural hospital, you might only have 10 or 15 minutes per patient, and so if you don't get an answer from a specialist in that time period, often it's too late. Every form for the different specialties has got a slightly different approach to the information that you must fill in. So, for example, on the left there's cardiology, where you can upload a picture of the ECG, which records the different heart rates. In the middle, you can see there's a man that you can kind of color in with your finger, and this is for the burns patients. And then it calculates the fluids that you must give the patient even before you refer. And the other example for ophthalmology on the right is that we have a vision test built into the app. This means that the busy specialist gets exactly the right information they need to make a decision quickly. The next step is that they are prompted to refer to a specialist in their area, and the person on call is listed. So this can save a rural doctor literally 40 minutes on the phone, because often, well, the old system was that you had to go via your hospital switchboard to the referring hospital switchboard. They would bleep the specialist. When the specialist had time, they would then call you back, and it's a very, very long process just to make a phone call. And with this system, it connects you directly to the doctor on call. You don't have to know the person personally, and just connects you straight away. The specialist then receives all the information in the perfect kind of way that we need to make a decision quickly. And then there's the online, also inbuilt chat, a nice secure chat, all protected and POPI compliant, as Taryn mentioned earlier. Now you can see an example of a chat, and the 2 health workers, the specialist and the primary healthcare worker, can then discuss the case and decide what to do and how best to help the patient. One thing we noticed was that at the end of every month, we publish the specialists' response times to the entire department. And what you very quickly see is that people who were slow to respond before suddenly start responding a lot quicker. And our average response time now is less than 15 minutes, which means that the rural patients get a specialist opinion within 15 minutes, which I think is actually better than you'll get in private healthcare in South Africa in some areas. One of the main advantages of Vula is that often people just don't know what to do with specialist cases. So when the specialists discuss the patients with the health workers, they can make a plan and often help the health workers on the ground to manage the patients there. This is real data from the Tygerberg Ophthalmology Department for July 2017, and you'll see that in 34% of cases, the specialist was able to guide the primary health worker through the management of the patient, and the patient didn't have to travel vast distances just to get a specialist opinion. There's a huge cost saving here, both in terms of time and money, for both the patients and the health system. This is an example again from the Western Cape, where you can see where all the referrals come from. And so you can see the yellow blocks are where the sort of fewer referrals, and the redder you get, the more of a hotspot it is, and that's where the patients are being referred from. And this helps the health managers realign their health services and make sure that the right doctors and the right specialists are in the right place. And this kind of data just really wasn't visible before we started recording it. With the national health insurance coming into effect, hopefully in the future, you'll start to see more of a crossover. So this is an example of private patients already being referred into the public sector because they didn't have medical aid to cover some of the conditions that they needed treatment for. What we found really exciting is that the health workers learn a lot from the specialists. Just to give you one example from Vredendal, there's an ophthalmic nurse there, which is about 8 hours north of Cape Town. Initially, she sent a lot of referrals through, literally sort of handfuls a day, and then they tailed off, and I thought maybe she had left the area or perhaps stopped doing ophthalmology. But when I phoned her, she said no, she knows what to do now, and she was starting to treat patients on her own. Soon after that, her referrals started to pick up again because she was spotting complicated eye cases that she probably missed before. She then became very keen on eye care. She won Ophthalmic Nurse of the Year 2 years ago, and actually she set up an eye clinic with surgical equipment there now, and you can actually get cataract surgery now in Vredendal. So although Vula just played a small part in that story, it shows how distance education can really change the way healthcare is managed and done. So let's take you back to that initial patient that I saw in the Matruleni Hospital. That patient had a condition, and the medication that he needed was in our hospital. I just didn't know at the time. And when I went back there 7 years later to do an eye clinic and to help see some patients, he came back to me and he still had this letter in his hand. So this photo was taken 7 years after I wrote it. And he'd gone blind in that eye just because I didn't know how to treat that condition. And all I needed was literally a simple message to tell me which medication to use. So Vula is a very personal thing for me because I really see that it's helped my practice, and it's starting to change patients' lives now across other provinces and other specialties. So thanks very much. I hope that you've enjoyed learning a bit about Vula, and please feel free to go to our website, learn more, and contact us.
Thank you very much, everybody, for sharing your expert knowledge and insight with us today. And thank you, too, to all our attendees of Digital Week. It was great to have you with us. Thank you for tuning in to hear more about eHealth initiatives on the African continent. If you would like to continue the discussion, check out connectingafrica.com for all your latest news and industry developments, as well as at Connect Africa on Twitter, Facebook, or Instagram, or just search Connecting Africa. And why not join us in Cape Town for the 20th anniversary of AfricaCom between the 7th to the 9th of November. We'll be having a dedicated digital health clinic, as well as 3 days of content, 400 speakers, and 450 exhibitors over 2 exhibition halls, mapping Africa's journey through the 4th Industrial Revolution. You can even attend the exhibition and a wide selection of talks and presentations for free by signing up for your AfricaCom Visitor Pass. Check out the event URL there, or just search AfricaCom 2017. See you again next time for another Digital Week webinar. Thank you. Goodbye.